And those are areas that we worry about as well. So those type of things. Spitting up blood is always a big one. If someone has a cancer on the voice box, they may potentially spit up some blood. Then there are more subtle ones. I had a patient come in recently with ear pain, and that was his only symptom, but he had ear pain for about a month, wasn't getting any better. It was thought he may have some fluid in the ear because he initially had a cold. But I looked at his ear, I said, there's no fluid here, but he's a 2-pack per day smoker. Said his voice hadn't changed, no changes in swallowing, but I just didn't like the history. And the reason I didn't like it is cancers in the throat can give you referred pain to the ear. So I put the little flexible telescope in, and he had a cancer on the top of his voice box, so it wasn't on the vocal cord, it wasn't affecting his voice. All it was doing was giving him this referred pain shooting up from the throat into the ear, and we diagnosed it early, and he's being treated and doing very well for that. So there are some of these subtle symptoms, you know, ear pain being one of them, where ear pain in a smoker, especially if there's been any voice change, but even if there's not, we need to look at the voice box. That being said, these things are caught early if patients come in early with that. There's a very negative side where a lot of patients are in denial. They know they smoke, they know they're at risk for these head and neck cancers, and their thought is, if I don't go to the doctor, I won't find out about it. So we have the patient who comes in who now says they can't open their mouth, and we look back there and we see a huge cancer eating into the jawbone, eating into the muscle where they can't open their mouth because the cancer is preventing them from doing that. Those are late-stage disease, and unfortunately more than 50% of patients with these cancers present with late-stage disease.
Okay, so really early detection is key.
Early detection is absolutely key.
Right. I suppose and they probably do feel badly, I mean, because they feel they brought it on themselves. And
it's a lot of guilt with this cancer.
Yeah. So now, does that lead to more depression, would you say, than, say, with other cancers, Meg?
I believe so. In my working with these kind of patients, not only does it have the precipitory type guilt, then there can be a lot of blaming by even other family members. So I think you do see a lot more depression. And you can see a lot more depression even in the treatment, because with some of these head and necks, we might be talking some altering surgeries. That, you know, we are a society of what we look like. And now some of these surgeries, especially for the latent, can be very massive. I mean, they've gotten to perfect this. I mean, they can take out jaws and everything else. It's amazing what they can do, but it's also very disfiguring very often. And yes, there is reconstruction and there is rehabilitation, but that doesn't happen right away. Often you have to do the massive surgery, come back, do the chemo radiation, then we go back for the reconstruction. So you could be living with something that's not what your norm is for a year or two, and it can be filled with depression.
You probably don't want to leave the house if you don't feel good about the way you look, obviously. Yeah. Wow. So, so when it comes to treatment, you go. It's like other cancers. It would be chemotherapy and radiation, probably.
There's a lot of treatment options here. The patients that we were talking about, they come in, they have some symptoms, and we have a finding. Typically, with those patients, we'll do some imaging, CAT scan or an MRI scan. If we know it's a cancer, we'll do a PET scan, which helps us detect if there's cancer activity elsewhere. For most of these patients, we will take them to the operating room and under general anesthesia do some type of biopsy, usually not a big incisional type of thing, but just something right through the mouth where we take a small piece of tissue to make the definitive diagnosis. Occasionally, we can even do that right in the office if it's really right on the tongue or right up front in the mouth. And sometimes that saves the patient a trip to the OR, particularly if they have other medical problems. Patients who are heavy smokers may have heart disease or lung disease. Once we've made the diagnosis, it depends on where the cancer is. Early stage cancers usually can get one type of treatment. So if you have a cancer on the tip of your tongue and it's pretty small, less than a couple of centimeters, we can usually do surgery to remove that. You'll still have excellent tongue function and you don't need chemo, you don't need radiation. Cancers on the voice box, in many cases, we'll actually do radiation because that will get rid of the cancer completely, small cancers, but the patient will have almost a completely normal voice. Whereas with surgery, we may have to take part of the vocal cord out for that. And there were some newer ways to do that surgery, but typically we lean towards radiation. As I said, many of these patients present with later stage disease, and we stage through stage 1 and 2, which are early stage, and then stage 3 and 4 are later stage. Stage 3 and 4 cancer always requires at least 2 treatment modalities, meaning surgery and radiation or chemo and radiation, sometimes all 3. Radiation always factors in for those later stage cancers. And we're very lucky that with chemo and radiation, beginning with studies that started with laryngeal cancer, we're often able to preserve key structures that we used to have to remove. So we can preserve a lot of people's voice boxes, whereas before we had to take those out. so patients can still maintain their own voice. We can still save a good part of the tongue with chemo and radiation, whereas before we'd have to take out part of the back of the tongue or part of the back of the throat. So we've come a long way with the treatment, and even with patients with later stage disease, we're seeing better results in terms of curing the cancer. But as Meg alluded to, there are so many issues with functionality in this area. So if you have to remove someone's jaw, there is a big cosmetic aspect. And Roger Ebert, the film critic, great examples of him in a recent magazine where you see how they've reconstructed his jaw, but how he looked initially after the treatment. You know, with Michael Douglas, we're hearing so much about base of tongue cancer, and we've really come a long way in the public knowledge about this because of these key figures who have been very open about their disease. But I'm fortunate. I have patients in my practice who are now 10 years out from chemo and radiation for base of tongue cancer, the back of the tongue. I also have pictures in my slides that I give to the students in the lecture I give, where I used to cut those tumors out. And these patients without function of the back of the tongue have trouble speaking. They're often tracheotomy dependent because they can't protect their airways, because saliva goes down and causes them to have trouble breathing, and they can't eat or drink. So even though it looks like they have full function, they don't. And when they go to eat or drink, everything goes down into the voice box and they choke, or they get pneumonia from that. So those patients end up being feeding tube dependent for the rest of their lives. So there's a lot of issues with breathing issues where they need a permanent tracheotomy. Someone who has their voice box out has to breathe through the hole here, and we can reconstruct their voice over time. But it's a lot of work, as Meg said, and that's very depressing. Or they end up being G-tube dependent for the rest of their lives, or they have to eat a very soft diet, because even though the jaw has been reconstructed and we can do miraculous things with that now, they still don't have the strength in that newly reconstructed jaw. They'll never eat a steak again, or they'll have permanent dryness in their mouth from the radiation, so there's certain foods they have to avoid. They have to be more meticulous about their dental care. Many of these patients have poor dentition from the smoking or from chewing tobacco. They have to have all their teeth removed so that when they get the radiation, they don't end up with a severe infection in their jaw that can actually cause a need to remove the jaw, not from the cancer, but from the treatment. So it's a very tough surgery, or a very tough treatment, I should say. But we do a lot more with chemo and radiation now, which is nice. We can preserve a lot of the function. And as a result, this is why we have a cancer center. It's multidisciplinary. It's not just the surgeon. It's the surgeon, the ear, nose, and throat surgeon in most cases. The oral surgeons are involved, radiation therapists, the medical oncologists, and then just an unbelievable staff around that, the nursing staff, social work, psychologists, swallowing therapists, speech therapists, radiologists, the anesthesia who knows how to put these patients to sleep for biopsies because their airways are often restricted by the cancer. So there's a whole set of risks really unique to this cancer, and as a result, a whole set of treatments and support for the patients.
Okay,
and
so
it's nice to do this.
Yeah, and a team approach, obviously.
Yes, it's nice to have a team to do this.
Come through it. Wow, so it's really just amazing to hear you talk about how devastating it can be to someone. I mean, you probably lose your sense of taste, you lose your ability to swallow, and I don't, it just seems like an awful lot to trade off for cigarette smoking or something. But people don't make that connection, obviously, when they start.
And it's so addictive. And we do have the patients who smoke through their trachea. I have patients who do that. I have the patients who come in, and I've taken off a significant part of their tongue. I had a woman come in the other day. I resected the whole bottom of the floor of mouth area. Thank God she's doing great. But her and her husband still smoke, and he now has something on his tongue. He had me look at the other day, and he needs to come in for a biopsy. I feel bad for them, but they cannot stop smoking. And I'm very non-judgmental when I talk to these patients, because they can't stop, and you feel really bad for them. And there's many ways, and Meg can probably address this more than I can, smoking cessation programs. We're working really hard at that, but I really feel for these patients. It's really an addiction.
It is.
Do you try to get them into a program?
We offer it. It's something that I've come to terms with also, that you really need to want to quit. Because it is probably, and I've worked with substance abuse for a long time, I think it's almost harder than what I have done with my patients who have had drug abuse issues. It is a very tough drug, and it is a drug to stop using, because it's socially, even though it's becoming more socially acceptable, it's still kind of acceptable. It is still part of the mainstream. And I think it's very hard for people. There are meds. I mean, Chantix, everybody knows about Chantix. But when you use Chantix, you can also have extremely vivid, horrible nightmares with it. So there's side effects to that. There's smoking cessation programs where they let you smoke the first 2 weeks, and then you go to weekly meetings and you stop smoking, and you... But it's still very, very, very difficult.
Yeah, and I suppose for some people, too, if you have ever used smoking as a coping mechanism, you're now at a time where you really need some, you know, you have to cope a lot with what's going on here. So to have that taken, you know, it's probably very difficult to then cut that out at the same time.
And the other thing I see, and I'm not saying it's right or wrong, but I see it a lot with my lung cancer patients. I've smoked for 30 years, and now you're telling me I've got to quit? And it's like kind of, why am I shutting the barn door after the horse got out?
Right.
I see, right.
Do they have that willpower to do something where it's already, unless it's very early stage disease and we can convince them that it's going to make a difference, people have a hard time visualizing that it's going to make a difference. They've already got the cancer.
Right.
Even though we tell them they do better with treatment and you have more success rate with the treatment if you do quit, it's harder for them to get a grasp on. They've been doing this for 40 years. Now they've got it. Why are they going to punish themselves more?
Right, right.
So it's very hard to convince someone unless they really want to.
Right.
And I'm sure some of the other treatments that they're having are not easy to go through. So
definitely,
that's, you know, so they're having that battle to
and
fight right now.
And if it's been a 40-year coping mechanism, if that was your way to cope, now you're asking them not only to make a lifestyle change, but learn a whole new way of living. It's hard. I feel for these patients.
Yeah.
And it does make the treatment harder. We tell them that their throat burns more, they don't heal as well after surgery if they keep smoking.
I see.
We try to impress upon them the risk of second cancers developing, even if we treat the initial cancer and we have good success with that, they're at a higher risk for developing a second one if they continue to smoke.
Okay. Well, we've learned an awful lot here. There's so much information here that you've shared with us and to take in, and that's good to know. And so we're learning that it's easily treatable when it's caught early.
Yes.
And so that's the main thing, is get in there early. Don't let any of these symptoms go, you know, delay. Don't delay seeing your physician.
Don't be afraid to see us.
Right. Okay. So come in early is the key.
It's relatively painless for us to take a look at the whole head and neck area.
And try to work on those lifestyle changes. That will be good.
Yes.
And then the other thing is screening is probably, we have just a couple minutes. So what about screenings coming up?
May is National Head and Neck Cancer Awareness. It's actually a week in May. We will be hosting, with their help, thank God, a screening program. I don't have the exact date yet.
Okay.
But if someone calls me in April, I can tell them when the screening is. It is free. It is easy. It's quick.
Painless.
Painless.
We just look in your mouth.
Okay,
Yeah.
Excellent. And maybe your dentist can do some of this too.
Yes.
The dentist actually does something called oral cancer screening.
Okay.
And that is in April. We will be having one for that also.
Okay.
So if people want to call me, like even March, I can tell them what's coming up.
Okay, and also just keep your eyes open for any publications, any sort of ads in the newspaper
There will be
or
an ad in
radio
the Lowell
spots
Sun.
that might promote these. So this is a good way to get involved with these screenings if you don't want to make an appointment and find out whether you're at risk or at additional risk for one of these cancers. So, okay, so we'll look at that. Oh, the other thing I want to mention, too, is that I looked at cancer.org, or excuse me, cancer.gov. It's a National Cancer Institute, and that had a lot of valuable information as well on head and neck cancer. I want to thank you both for being here today. It's been a wonderful half hour learning all about head and neck cancer. So thank you for coming in.
Thank you for inviting us.
Okay, and thank you as well for joining us, too, at home. See you next time.